The therapist now works through specific special tests to highlight certain structures, starting with the patella. Initially, he checks the mobility of each patella, and then the underside surface of the patella for damage and pain, by scooping it against the femoral condyles. Also palpating under the medial and lateral borders. And finally, the centre of the patella by a compression force. The knee is then flexed and moved with the hand applying pressure to the patella, looking for crepitus, pain, as the patella moves through the articulating condyles. The therapist is now going to assess the collateral ligaments, starting with the medial collateral ligament and the lateral collateral ligament. Initially, he will do a laxity test. This is just to check if there is any excess play in the joint, and to compare this, he will need to move the other leg. The ligaments are then checked individually by a medial stress to the medial collateral ligament and a lateral stress to the lateral collateral ligament. The knee is bent and the ligaments are then palpated individually, going around the joint line first to locate where the ligaments are, and palpated in the knee bent position. And then the leg is straightened and they are palpated from their femoral attachments down to their tibial and fibular attachments. The cruciate ligaments are examined in a similar way. The anterior-posterior cruciate is initially tested by the Lashman's test, and this is a comparison test, again looking for laxity. Having completed the Lashman's test, the knee is then put into a 90-degree angle, and the ligaments are going to be assessed initially by observation, looking to make sure that the tibia has not dropped backwards, and that would indicate a posterior cruciate rupture. And then the ligaments would be tested by sitting on the feet and pulling the joint backwards and forwards. This is again a laxity test and is called the drawer test. Having checked the laxity, then stress is applied to the anterior cruciate and to the posterior cruciate ligament. This time, the knee is now going to be checked for a meniscal fault, and the thumb and finger applied onto the compartments, medial and lateral compartments, just below the patella, and the knee is rotated clockwise and anti-clockwise several times, looking for any clunking and clicking, any pain as the tibia is compressed and ground against the femur. The compartments are then palpated, looking for any tenderness along the joint line, because directly under this is where the actual meniscus lie. The patient is now asked to turn over so the posterior aspects of the joint can be checked. Initially, they are checked by a test called Apley's distraction test, and this is where the tibia is separated from the femur, so that any loose bodies or possible loose meniscal fragments can fall into the joint, and there into Apley's compression, where pushing down and applying a compression force from the tibia through to the femur, a rotation aspect is given. And in fact, grinding the tibia into the femur, this may well pick up a meniscus or a loose body problem. Whilst in this position, we can look at the common injuries of the knee. At the back we have the fairly common hamstring strains, and moving down into the back of the knee, strains to the popliteus muscle, and also the popliteal bursa, which if irritated swells quite considerably. The posterior attachment of the posterior cruciate can also be sometimes palpated in this area. And we also have the gastrocnemius muscles, which can be strained at their origins. The front of the leg is now examined, looking at the quadriceps muscle, rectus femoris, and the quadriceps expansion, where the quadriceps actually attaches to the top of the patella. The patella itself, looking for problems underneath, such as chondromalacia patella and painful patella syndrome. The lower pole of the patella, this is where jumper's knee may well occur, and the patella tendon itself, for tendinitis. At the distal end of the tendon, inserting into the tibial tuberosity, is where Osgood-Schlatter's disease can take place. Also look at the bursas, the suprapatellar, prepatellar and infrapatellar bursa, and that sits directly underneath the patellar tendon. On the inside we have the sargent or pes anserinus bursa, underneath the tendons of sartorius, gracilis and semitendinosus, and on the outside we have the iliotibial band bursa. And where the band crosses over the lateral condyle of the femur, excessive friction can cause inflammation and pain, and this is known as runner's knee. Moving round to the back of the joint, we have the popliteal bursa, and this is sometimes called a Baker's cyst.